Right, we're going to move on now to our penultimate session of the conference. It's a keynote speech from the Health Education England Chief Executive and Chief Workforce Officer, Dr Navina Evans. So please welcome them to the stage.
Good afternoon, everyone. Please don't go. You know, when you go to a gig and you actually come to see the headline, which is Julian Hartley, and then you get the warm-up gig, that's me, and you think, oh, what's she going to be like? I promise you that you'll go away thinking, well, she wasn't too bad, but you'll still be waiting for him. So, my name is Navina Evans, and I am Chief Executive of Health Education England and a Chief Workforce Officer for NHS England. I want to thank you for giving me some of your time, and thank you for giving me the opportunity to continue this conversation with you. Started it with many, and hopefully will continue after today, about embedding inclusive leadership to support the well-being of our NHSE workforce. Now, we're all used to a lot of change, aren't we? And that familiar saying, change is the only constant, I think it feels particularly true right now. And there's been some quite exciting change for us all. The placing of integrated care systems on a statutory footing from the 1st of July this year represented a significant milestone in the creation of the new operating model for the NHS. And we shouldn't underestimate how significant this change will be for how health and care will be delivered, and for all of our partnerships at every level, national, regional, system, local, and place. So exciting times. And at the same time, NHS England is merging with Health Education England and NHS Digital to create a new NHS England with the purpose of leading the NHS in England to deliver high-quality care for all. NHS England's new operating framework sets out how it is changing the way it works to best empower and support local system partners to deliver your responsibilities. So this new organisation gives us, I believe, a once-in-a-generation opportunity to properly align finance, service, and workforce planning. And that is something we owe to the current and future generations, and we owe it to them to take that opportunity. It's hugely exciting. So we have this opportunity to make the NHS even better, to make sure that money is spent where it can make the most difference for our patients, and again, to bring workforce, education, and training to the very centre of how the NHS plans, organises, and delivers. So this new NHS England will see us alongside and in step with the regions, ICBs, and providers, and completely aligned to service and financial planning for the benefits of the people we serve. That's quite a big ask, I think, and when I think about it, I get sort of mixed feelings, goosebumps, a little bit nervous, a little bit excited, and I often return to the values of the NHS Constitution as an anchor. And as a framing for this speech, I thought they remain as important today as they ever did. I really do love returning to this particular image and the way in which we think about the Constitution and the values. Working together for patients, respect and dignity, commitment to quality of care, compassion, improving lives, everyone counts. Pretty much sums up inclusive leadership in making these values a reality for everyone we serve and for the more than 1 million people who work in the NHS. So inclusive leadership is clearly there in the values of respect and dignity, in compassion, in the fact that everyone counts. But it's also there in the values of working together for patients and the commitment to quality of care. So it can only deliver better care for everyone. We've heard the word productivity a lot lately, especially as we focus on the economy. I actually quite like that word because it's not a starting point. It's not something you do. It's the outcome of other actions. It's what you get when you're doing other things right. Now, I'm going to share an example with you, and I know this is only one of many. And last night when I spoke to someone who may be here was a bit cross that I was using this example and not one from their organization. But I can, as I say, I can use many, many different examples. At Bradford Teaching Hospitals Foundation Trust, the outstanding theatre service led to significant improvements in staff engagement, morale, and theatre productivity. And I really love that connection between engagement, morale, and productivity. So responding to patient and staff feedback and data on staff sickness, recruitment, and retention, this program enhanced with the staff, and they engaged with staff and used inclusive leadership to change their culture. So the results for Bradford is that what they've seen is improved productivity with an increase in planned theatre sessions. So they've seen that. And they've seen improvements in vacancies and in attendance. Now, I'm sure this is a constant effort for them. They can't just sit back and relax because this is a continuous program of improvement and your inclusive leadership is tested. But what I think this demonstrates is that better productivity happens when staff feel engaged and have a say in how they work. Better productivity happens when people feel included and when they feel they belong. Better productivity happens when we invest in our people, in their development, and in their well-being. These aren't just sound bites, and this is just one example. I know there are hundreds that you know of. So, data suggests that there is a link between higher staff engagement scores and better productivity. We also can show that higher satisfaction with inpatient care is also significantly associated with more staff reporting equal opportunities for career progression and with fewer staff experiencing discrimination. This is something I remember from my days in the trust where we had a lot of service user feedback which correlated with how staff felt we engaged with them. Inclusion and inclusive leadership lead to better performance and better patient outcomes. That is why I was pleased to see inclusive leadership reflected and referenced specifically in the report by General Sir Gordon Messenger, which was published in June this year. The second recommendation of the Messenger report was, it said, to take positive action on equality, diversity, and inclusion. This recognizes the importance of putting these values at the heart of our leadership. So NHS England is engaging with leadership, stakeholders, and industry experts to help shape and drive forward how we will respond to the recommendations of the Messenger report. And I hope that many of you will help us to shape that response. I want to talk a little bit now about inequalities. Other people have mentioned it, but I think we do need to remind ourselves that one of the ways we can address unacceptable health inequalities is by ensuring that the NHS workforce is representative of the communities it serves. And that means having a truly diverse workforce at all levels. We must remind ourselves that we know, for example, that last year we found that Black women are still 4 times more likely to die during childbirth. That is really stark. So to achieve a goal, it is the responsibility of all of us, all leaders at all levels, to know what part we play to improve equality and to reduce health inequalities. I don't think any one of us can say that is not in our ambition or our responsibilities. Now, the NHS workforce numbers roughly 1.4 million people, the 5th largest workforce in the world, if I remember, after Walmart and McDonald's, I think. Yet, despite that number, we know that we need a workforce that is both bigger and more flexible to meet the increasing demands on our NHS. They've got to be high quality, skilled, compassionate, well-educated workforce that's fit for now, but also into the future. And that should be part of our number one focus as inclusive leaders. However, more in its own right will not be sufficient. We also need to think about different, and we often talk now about more and different. The challenges of clearing the elective backlog, the demands of an aging population, the expectations of the workforce of tomorrow. People don't want to work the way we work now or the way we used to work in the past. So people want greater flexibility, they want modernization, and all of this requires us to innovate and find creative solutions to engaging with our workforce. Because it takes time to train the social care and health workforce, the investment decisions that we make today will shape the care we are able to deliver in the future. Just as the care that we provide today is largely the consequence of decisions that were taken up to 15 years ago. So whilst we are preoccupied with the here and now and the workforce concerns that we have today, please may I ask you to engage with us in thinking about the workforce of the future. I was delighted last year when Health Education England was commissioned to create a long-term strategic framework for the health and social care workforce. This is to help us to determine how many people with what skills, expertise, and values are likely to be needed by the social care and health systems of the future. So through collaborative work with partners, we've looked at the key drivers of long-term workforce demand and supply and their impact on the shape of the future workforce. And we have identified the main strategic choices that need to be made. Clearly, understanding with precision the requirements for future health and care workforce becomes much more difficult the further you look into the future. Variables, Amanda spoke about them, such as advances in technology, our political context, change in service delivery models, all these things evolve and make specific predictions harder to make. However, we have started with the needs of people, of staff, and of patients as the best line of sight for this work. So for the first time, regulated social care professions are also included within the scope of this work. And this emphasizes the importance of improving integration between health and social care. So in advance of more detailed service plans, our combined ambitions for the future of care, work, and education provides us with a framework for the shape of the future workforce, what we will most likely need in 15 years and beyond. So this framework that I'm talking about is the first and necessary step in the planning process that needs to happen at all levels, across all timeframes, using all of our collective levers. And this will inform professions and pathway-specific strategies and plans, integrated ICB 5-year strategies for health services, ICP integrated care system plans, which will be drivers for and also enablers of future integrated professions, pathway-specific, and workforce and education strategies and plans at a range of levels. Amanda spoke about our more detailed long-term workforce plan, which is about to follow. This will set out the size and shape of the NHS workforce in timeframes up to 5 years, 10 years, and 15 years, and how that workforce might be best supplied. And as I say here, the further out you get, the more difficult that becomes. But the long-term workforce plan aligns with and builds on the priorities which we set out in Framework 15. So this was commissioned by the then Secretary of State, Sajid Javid, in January of 2022. And the plan was asked to set out and supply and demand scenarios and projections for the short, medium, and long term for key workforce groups and professions. We were asked to identify the mix and number of staff needed in all parts of the country to deliver high quality and productive care in future. The plan should support integrated working between health and social care. It should set out the action and reforms needed to close supply gaps through domestic training and ethical international recruitment, improve retention, increase workforce productivity, and have a modern and inclusive employment culture. So, thinking across the range of national policy levers, for example, pay, pensions, professional regulation, contracts, terms and conditions, training, skill mix, leadership, and culture. So, not a big ask. We are engaging with a broad range of stakeholders in developing this plan, and key conclusions of the work will be shared with government later this year. And our aim must be more people working differently in a compassionate and inclusive culture that reflects those values of the NHS. So as well as inclusive leadership, I was also asked to talk about the well-being of the NHS workforce. The well-being of staff was, of course, important way before COVID-19, but the pandemic really showed us how critical it is that we look after our people. It also really showed us what we did well, but it also showed us where we needed to do much, much better. We need to make sure that people stay, and that they stay, and that they stay well. NHS England has worked with provider organisations to develop the voluntary wellbeing guardian role, and there are now 211 wellbeing guardians in place across the NHS. So that's 93% of large provider trusts with a senior leader at board level who, in addition to their main role, ensures that board members maintain their focus and commitment on the health and well-being of their NHS people. And I'm hoping to have more conversations, detailed conversations with those wellbeing guardians to find out how they know, and what their organisations are doing so that we can learn from each other. As part of NHS England's National Retention Programme, 23 exemplar sites are implementing bundles of interventions based on this people promise and evaluating the impact of these on staff retention. It's still early days, but our initial findings are showing an improvement in staff engagement scores, which, as I mentioned earlier, are associated with other improved outcomes. But it always starts with engaging people. Wellbeing support must also extend, please, to our students, our learners, and our trainees. They are, after all, the NHS people of the future. This is why HEE has established the Enhancing Junior Doctors Working Lives programme to support our doctors in postgraduate training. And this recognises that doctors aspire to have flexibility in pace of training, opportunities to take breaks from training, opportunities to work and train less than full time. And it's really important for us to listen to how they want to work. So this programme aims to make tangible improvements in medical education and training to positively impact doctors' working lives and well-being, and the flexible training agenda has remained at the forefront of this. It's difficult to implement, but it can be, and it has been, in many of our organisations, and we can certainly spread how to do that. Now, each of the initiatives that I've described would not be sufficient in itself. So, once again, I will reinforce that we need to work with all levers at all levels, and it is the collective impact of these interventions which will make the most difference. And this is why it is so important that we put our people and the well-being of our people at the centre of what we do. After all, the NHS is a people's business. It's our people, it's their knowledge, it's their skill, it's their commitment, and it's the culture that we create that drives what we do and how we do it. It's all of these plus our values which will attract the best people to the NHS and, more importantly, keep the best people in the NHS. So to do so, we must put all our levers at all levels, system, local, regional, national, and this must include retention, a relentless effort and focus on retention, thinking about our domestic supply differently, making sure that we engage in ethical overseas recruitment, making sure that education and training is a golden thread that better prepares all of us for this exciting but challenging future. Our leadership behaviours and qualities will continue to be tested with greater and more open scrutiny. I, for one, welcome it, and I hope that you do too. We will be experiencing challenging times that tests all of our ability. We've risen to them in the past, and we can continue to do so in the future. We won't always get things right. That's okay, because we'll continue learning. We must listen and lead by example. We must speak out against all forms of discrimination. We really need to use our voice as leaders in that space. Inclusive leadership is a personal responsibility of each and every one of us, and it is critical to meeting the challenges of today and the demands of tomorrow. And that is how I believe we can stay true to the values that our NHS is built upon. Thank you.
Thank you. Thank you so much, Navina. Lots of interesting examples and ideas there. One issue which has been coming up a lot today, and it was in the last session as well with Amanda Pritchard, was about the anti-racism stance. And this person asked a question. I felt they didn't quite get they didn't get an answer on the anti-racism issue and NHS England stance. So will NHS England look to take an anti-racist stance, recognising the huge impact COVID had on our Black, Asian, Filipino staff, 68% of health and care staff that died? Can we address this, please?
Sure.
What lessons have you learned from that?
So I can talk about what I know many organisations have done, and actually what we did in HEE. And we made a decision to move from improving race equality to actually tackling and becoming anti-racist. And it's quite a shift that has to be made. And I think it's one that an organisation, any of us, can't take lightly. And certainly when we made that decision in Health Education England, it was a decision that the board had to take. And myself as chief executive and Sir David Bean as chair made that commitment. It had quite interesting consequences.
What consequences?
So very mixed, actually. There were quite a few people that found it really challenging and really difficult. And they felt much more comfortable in the I want to improve equality space and much less comfortable in being anti. So I think it's a really important question to grapple with.
But how, I mean, if you could give an example of how practically that will be felt differently by staff, because I think that's the question.
Yeah. So, well, what I know from the organisations that have done it and where we've done it in HEE is that we have more and more people are approaching it differently. So it's about challenging racism. It's about having that conversation. It's about understanding that it exists and what it means. And then it's also about looking at all of our structures and processes within the organisation, recruitment, our education and training processes, because we're an education and training organisation, and really start to examine, is it just that it's sort of clunky, clumsy, or is it actually discriminatory? And then, of course, it then extends into other areas of equality. We started then to have to look at how our approach to women and to people with disabilities. So it is it does open up a different kind of discourse in an organisation.
Yeah. To what extent will future training include leadership training at junior, mid-career and senior level? So many clinicians, in the view of this question, are ill-prepared to take on leadership roles, even though they may be brilliant clinicians. The military do this well. Are we learning from them?
Yeah. So that's, again, a really good and timely question, and it was something that came out in the Messenger report. So we are actually engaging through NHS providers and with many other colleagues about how we should be doing this. So yes, leadership development is really important. It isn't something you can just expect everybody to be able to do. What works? We need to find out what works. And then there's a question of, we don't want to do, well, I don't know, we don't want to do that kind of sheep dip kind of way of doing it. Maybe it doesn't work. Does it work? We need to ask people. And then is it kind of nice to do and voluntary, or is it to be mandated? These are all questions that we're asking ourselves, but we do know how important it is at every level. It's just a question of how we make sure that we develop it and that it's actually a useful exercise with good outcomes.
Well, you raised that question of, it's essential, how do we develop it? Navina, will funding be provided to train the workforce of the future? Significant additional investment is needed, which won't pay back immediately.
So you mean funding for this is not leadership funding, but for just
more
generally
workforce
yeah,
training.
I think that's a really good point, and I think that's what we suffered from over the years, because you're making investment decisions where you see things, very in the distant future. So our previous Secretary of State, and I think this morning, current Secretary of State talked about the fact that Jeremy Hunt, when he was Secretary of State, made the decision to expand the medical school places.
Yeah.
That was some years ago, and they are only just coming out and feeding into the system. That's why I'm really keen that we all engage in a way of thinking which is about foresight and not forecast. We might not be we might not be the leaders of organizations that reap the benefits, but the investment needs to happen now. So there's a question about how we make sure that we are able to think foresight rather than forecast. One other little thing, that many of our trainees and students and apprenticeships and volunteers, they're all our workforce now. And also they can then develop to be the workforce of the future.
Which leads to my next question, and several people have raised it, which is your view on processes for senior appointments in NHSE that don't seem to follow good practice, especially about increasing diversity. The issue is very rarely entry level. The issue is often about promotion at higher ends in the NHS, isn't it? And the lack of diversity still.
So
what are you doing to tackle that?
This is a question about more generally, or
there's a specific question about what's your view on recent processes for senior appointments at NHSE, and there's the view of this person that don't seem to follow good practice, especially about increasing diversity.
I have not been involved in senior appointments at NHS England, so don't feel like I'm qualified.
Do you have a more general view about the relative lack still, it seems, of diversity at senior levels?
Positions? Yes, absolutely. And our workforce race equality data demonstrates that. We work with the Race and Health Observatory to look at that particular issue. Yes, absolutely. Most organisations should have a plan to improve diversity in all of their organisations. Where I used to work in my old trust, that is absolutely something that at board level we paid very high attention to. But it's also about a pipeline, and it's also how you develop your staff to make sure that people have access and the ability to get a chance at those levels. And it's not just about the right thing to do; it's about the fact that it is a good thing to do for the productivity and for your organisation.
Yeah, no, your evidence is all about that. One last question. You made a really interesting reference in your speech to ethical overseas recruitment. And the questioner says, it was great to hear you use that phrase. I assume the anxiety one feels regarding this is not lost on you. The danger of continued inequality at its height is a concern.
Yes. So I think overseas recruitment is something that I am really keen that we open up the conversation about ethical recruitment. So we're talking about a global health and care workforce. So I would like us to talk about recruiting from a global health and care workforce. not just international recruitment. Because we are part of a system that we have to be responsible for what is happening across the whole world in terms of the global healthcare workforce. Then there is the fact that people want to work in different parts of the world. People want to learn in different parts of the world. So if that is the case, then we should be thinking about how we make sure that we look after people when they come and work for us, but also how we give back. And we've done this. We've got loads of examples of how to do this across
Can you give an example?
Organizations in England. Well, we have schemes where we develop fellowships where people learn and can take their experience back to their home countries, where we could invest in supporting training, especially now that we can train, virtually in other parts of the world. So I think we should be actively doing that with colleagues.
How do we address the inequality in cost of living across the country whilst maintaining a national pay scale?
So I'm glad someone asked that question because, again, if you look at, in NHS England, there is a cost of living hub which has recently been developed. So I would encourage people to have a look at it. And what we've done is we've gone and found out what excellent work is being done all across the country to support their staff around cost of living initiatives. And there is so much I didn't know about. So it's there to share and learn of things that we can do across the country. Different providers are doing lots of different things. And maybe if you're in a group or if you're in an ICB, you can come together to do things collectively. So there's already a lot of good evidence and good practice out there to support staff.
Right, in the very interesting times we're in, this is a good question. Is the Gender for Change still fit for purpose in the context of a workforce shortage when we need to think about how we enable people to do the work needed rather than setting standards they need to bring? Sometimes might not be needed, such as certain qualifications.
Yes, so I think a Gender for Change is a whole other conversation that we can have. However, I think the point about qualifications is a really interesting one, and how we so one of the things that we're doing in education and training and Framework 15 challenges is our assumptions about who can do what in health and care. And so we start talking about skills over roles. And some of the challenges that we have developed through our apprenticeships programs around entry routes into medicine, around what advanced practitioners can do, physician associates and anesthetic associates, really starts to open up those conversations about do you really need to have that person who's passed that exam to do that particular, deliver that particular role. And the strongest voice and the most important voice is that of our service users who tell us what they want is people who actually have the values and behaviours and then are technically good at what they do, as opposed to people who've passed loads of exams.
Thank you. We can take one question from the room if there is one. If someone's got a paddle and can spot someone with a question arm up, wave it. Otherwise, I have one more I can take off the glisser. I can't see. If you've got a question, wave your arm around wildly at me. No. Right, I'll take this one that I've got here. And it's quite a good one to finish on. Navina, can you assure us that the reorganisation of HEE will not reduce the diversity of the new NHSEI?
Will not reduce the diversity. Well, I would hope it would improve the diversity of the new organisation. It is Amanda's commitment and ambition.
Sorry, you can turn the lights down now. Thank you.
It's all right. It's what my mother does. It's really important. It's not just, like I said, it's not a nice to do thing. It's a really important thing to do if we are going to be an effective organisation. And that's diversity across the board. And we've got a lot of work to do, as have all of us in this space. So I don't see it. I see it as an opportunity to actually increase the pace and to make it even better.
Yeah, no, it's a really good conversation to have had. I think the workforce issue is kind of at the heart of every conversation taking place at NHS Providers this year. Thank you all, Navina, and thank you for your questions as well. Thank you.
Thank you very much.